Hi, hello everyone. Welcome to Dr. Ravichandra official YouTube channel for pathology topics. And in the last video, we have discussed RBC abnormalities. In this video, we will discuss WBC abnormalities. Before going into the topic, I request all of you to please like, share, and subscribe Dr. Ravichandra official. Let's start the topic. So, before going into the WBC abnormalities, we will discuss few important things about WBC that are asked in Viva or for in general purpose also. All the medical students should know these particulars. So in the WBCs there will be agranulocytes and granulocytes. So they are differentiated based on the granules. Agranulocytes will have no granules and granulocytes will have granules. So in the agranulocytes, there will be two types of WBCs that are lymphocytes and monocytes. And in the granulocytes, there will be three types of granulocytes: neutrophils, eosinophils, and basophils. The word suffix "phil" means granules. So these are divided into neutrophils, eosinophils, and basophils based on the granules type of the granules present in them, not based on the nucleus. So neutrophils, eosinophils, and basophils come under the granulocytes, and lymphocytes and monocytes will come under the agranulocytes. We will discuss one by one. Neutrophil, it ranges around 50 to 70% of the total WBC, and its size will be around 12 microns in size. The cytoplasm will be pink to orange in color, and the nucleus will be deeply stained and it is lobulated. There are fine pink to purple granules with coarse chromatin. These are the characteristic features of a neutrophil. Based on the lobulations, the nucleus will have lobules. They can be 3 to 5 or sometimes less than 3 also. So we will discuss the lobulations. Less than 3% will be in the form of band forms, and 10 to 30% of the neutrophils will have two lobes, and 40 to 50%, that is majority, will have three lobes, and 10 to 20% the neutrophils will have four lobes, and 5 or more percentage will have five lobes. That is less than 5% of the neutrophils will have five or more lobes. Coming to the eosinophil, it is ranging around 1 to 6% of the WBCs, and its size is around 13 microns. There will be large, round, oval eosinophilic granules, coarse red eosinophilic granules or coarse orange eosinophilic granules, which are the characteristic feature of a eosinophil. There will be a nucleus with two connected lobes looking like a spectacle shape. Basophil, these are very rare. Percentage will be around 0 to 1%, and they will have a characteristic blue cytoplasm and large purple to black granules obscuring the nucleus. Now coming to agranulocytes, monocyte, it is the largest leukocyte of size 15 to 18 microns, and its percentage will be around 3 to 8, and they will have a ground glass appearance, bluish abundant cytoplasm, and the granules sometimes may be present. They will be small, fine red to purple granules in few monocytes, and the nucleus will be horseshoe shaped and it is large and curved, and the chromatin will be condensed. Coming to a lymphocyte, it is small in size, 6 to 10 microns, and its percentage is around 25 to 45% of the WBCs, and they are the mononuclear cells with rim of pale blue cytoplasm and scanty eosinophilic granules, and the nucleus is homogeneous, single, and uniform with condensed chromatin. Large lymphocytes will be having a size of 12 to 15 microns, which are around 10% only. Now we will discuss WBC anomalies. In this, there will be smudge cells, hypersegmented cells, Pelger-Hutt anomalies, Jordan anomalies, Start cells, Ellie cells, hairy cells, Reader cells, Downey cells, pycnotic cells. We will discuss one by one. Now, first, smudge cell or a basket cell, ruptured WBC with free nucleus. Heavy pressure during smearing will result in a smudge cell or basket cell, and they are characteristically seen in chronic lymphocytic leukemias (CLL). Jordan's anomaly or foamy cells. These are having a cytoplasms with holes or vacuoles, and these are seen in towards old oxalated samples. And these are mostly seen in leukemias, infections, and chemical poisonings. Now, next we are discussing TART cell. It is usually a monocyte with an engulfed foreign nucleus, seen in drug sensitivity reactions. LE cell, usually a neutrophil with engulfed nuclear material of a destroyed cell, and these are the characteristic cells in systemic lupus erythematosus, which is a autoimmune disease seen mostly in females. Drumstick or bar body. Drumstick nuclear appendages will be seen on the neutrophils, basophils, and eosinophils, and the bar body or sex chromatin in females is characteristically present. In plain filter syndromes, males will also have a bar body. Next, leukocyte disorders. The WBC disorders are broadly classified into quantitative and qualitative. In the quantitative, they are again subclassified into malignant and non-malignant. Non-reactive are called as malignant and reactive are called as non-malignant. In the reactive non-malignant, there will be increased or decreased counts. In the non-reactive malignant conditions, they may be myeloproliferative diseases or lymphoproliferative diseases. And again, in the qualitative WBC disorders, they can be because of the morphologic abnormality or morphological changes or with normal morphology. You have to remember that WBC disorders are mainly classified into quantitative and qualitative. In the quantitative non-malignant, that is reactive, there will be increased count or decreased count. Increased count is neutrophilia seen in bacterial infections and trauma, lymphocytosis, increased lymphocyte count in viral infections, eosinophilia, increased eosinophil count in parasitic infections, basophilia, increased basophil count seen in CML, chronic myelogenous leukemias, and few allergies. Monocytosis is increased monocyte count seen in all inflammations and infections. Decreased counts. Neutropenia, decreased neutrophil count seen in medications and immune mediated reactions. Lymphocytopenia, that is decreased lymphocytes count seen in AIDS and carcinomas. Eosinopenia is decreased eosinophil count seen in marrow hypoplasia. Basopenia is decreased basophil count seen in stress and radiation. Monocytopenia is decreased monocytes count seen in regularly hemodialysis patients and in the patients with steroid therapy. Neutrophilia. The absolute neutrophil count will be around 2000 to 7500 cells per cubic mm. Neutrophilia is seen in bacterial infections, inflammations, stress like trauma, surgeries, hemorrhage, seizures, and when steroids are used for long duration, and they can be seen in malignancies and myeloproliferative diseases also. Neutropenia is seen in viral infections, drugs intake, post chemotherapy, severe sepsis, hypersplenism, Felty syndrome, neutrophilic antibodies seen in systemic lupus erythematosus, and bone marrow failure. Eosinophilia, it is called as eosinophilia when the absolute eosinophil count is more than 750 cells per cubic mm. Normal range of AEC will be 40 to 440 cells per cubic mm. And the conditions are allergy, asthma, atopy, parasitic diseases, helminthiasis, skin diseases like eczema, psoriasis, drug reactions, hypereosinophilic syndrome. Basophilia conditions, allergic reactions, CML, myeloid, metaplasia, radiation, and polycythemia vera. Monocytosis is seen in chronic infections, tuberculosis, brucellosis, malaria, malignancies, Hodgkin disease, and decreased in hairy cell leukemia. Lymphocytosis count around 1500 to 4500 cells per cubic mm, seen in acute viral infections like CMV, dengue, and parvovirus infections. Chronic infections, tuberculosis, brucellosis, syphilis, and hepatitis also show lymphocytosis. Infectious mononucleosis caused by Epstein-Barr virus also shows lymphocytosis. In few neoplastic diseases also lymphocytosis will be there. Coming to lymphocytopenia, it is decreased lymphocytes count seen in marrow disorders, steroid therapy, HIV infection, uremia, and post-radiotherapy. Coming to the quantitative malignant, they are subdivided into myeloproliferative diseases and lymphoproliferative diseases. Under the myeloproliferative diseases, they are AML, CML, polycythemia vera, essential thrombocythemia. Lymphoproliferative diseases, when lymphocytes are involved, it can be ALL and CLL. Lymphomas like Hodgkin's and non-Hodgkin lymphoma. And plasma cell leukemias seen in multiple myelomas, Waldenstrom, macroglobulinemia. Waldenstrom macroglobulinemia. Air rods. These are rod-like bodies that stain reddish purple in color, shown with the arrow in the picture, black colored arrow. And these are characteristic feature of AML. Reader cell. Lymphocytes with pseudolobulations is called as a reader cell. It's look like a clover leaf like nucleus seen in CLL. Reader cell characteristic features of CLL, clover leaf nucleus. Hairy cells are having cytoplasm irregular and gray blue hair-like projections, and they are trap positive seen in hairy cell leukemias. Coming to the qualitative defects of WBC disorders, with morphological abnormality, there will be Pelger-Hutt anomaly, neutrophil hypersegmentation, Alder-Rayleigh anomaly, Chediak-Higashi syndrome, May-Heglin anomaly. Pelger-Hutt anomaly. Failure of neutrophils to segment properly is Pelger-Hutt anomaly. There will be dumbbell-shaped bilobed nucleus seen in leukemias and other diseases. Hypersegmented neutrophils, also called as macropolycytes, they will be having more than 6 to 10 lobes, and it is characteristically seen in pernicious anemia and megaloblastic anemia. In the megaloblastic anemia, there will be hypersegmented neutrophils, and the important point to diagnose a megaloblastic anemia is there should be more than 5 lobes, that is hypersegmented neutrophils percentage should be more than 5% of the neutrophils. This is a characteristic feature of megaloblastic anemia. Alder-Rayleigh bodies or anomalies. Large coarse dark purplish eosinophilic granules are seen. There will be heavy granulation resulting in few Alder-Rayleigh bodies, which are seen in Alder-Rayleigh anomalies, mucopolysaccharide storage diseases, Hurler or Hunter syndromes. Chediac Higashi granules are very large red or blue granules seen in the cytoplasm, seen in Chediac Higashi syndromes. May-Heglin anomaly, there will be doll-like bodies and they are more prominent, and there is a triad of symptoms or signs. Thrombocytopenia, giant platelets, and inclusion bodies comes under the May-Heglin anomaly. Now we will discuss the qualitative defects of WBC abnormalities with normal morphology that comes in. There are two diseases, chronic granulomatous disease and leukocyte adhesion disorders. And leukocyte disorders, qualitative with morphological changes will be toxic granulation, Dolly bodies, cytoplasmic vacuolation, and infectious mononucleosis. Toxic granulation, there will be blue-black cytoplasmic granules in the neutrophil, and it is seen in very acute infections, burns, drug poisoning. Dole bodies, these are the small pale blue bodies located at the periphery, and they are the remnants of ribosomes and endoplasmic reticulum seen in severe infections and burns. Downy cell, it is a transformed atypical stimulated lymphocyte. So Downy cell is a lymphocyte, atypical lymphocyte, and this is also called as ballerina skirt cell, as the appearance is like the of a skirt, ballerina skirt. So these Downey cells are characteristically seen in infectious mononucleosis. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting pathology videos.